Welcome to AETCM, the emergency medicine channel. Today let us discuss about sarcoidosis. You should know why we are discussing about sarcoidosis in this emergency medicine channel. This is one of the most important differential diagnosis of bilateral lung infiltrations. We can see many patients who come with lung infiltration to emergency room, which can be pneumonia like viral pneumonia, which can be tuberculosis, which can be sarcoidosis, which can be post-viral pneumonia sequelae. Like so, lot of eosinophilic pneumonia, lot of differential diagnoses are there for an X-ray with bilateral infiltration. And here we can also get many other organ involvement, like patient can present with cardiac arrhythmias, cardiac failure, pericardial effusion, pleural effusion. So many other organs also can be involved in sarcoidosis. It's a chronic multi-system disorder, and here T lymphocytes and mononuclear phagocytes accumulate in tissues, and it leads to non-caseating epithelioid granuloma. You should understand the difference between TB and sarcoidosis. TB is a caseating granuloma. Here it is a non-caseating granuloma. That is the main difference. It is by pathological system we can make a diagnosis of caseating or non-caseating. Clinically, we cannot make out whether it is a caseating or non-caseating. It's mostly involved lung, but it can also involve other organs in our body. 30% of the patients can have involvement of other organs. And many patients can have spontaneous remission without any treatment itself. Patient can get complete cure from sarcoidosis. 50% of the patients can relieve without any treatment. The lung is the most important organ which is affected in sarcoidosis. 90% of the patient who is having sarcoidosis can have lung infestation. Mainly it looks like interstitial lung disease. Patient can have cough, breathlessness, fever, night sweats, weakness. Everything looks similar to tuberculosis. Pulmonary hypertension can be there in chronic sarcoidosis. Interstitial lung disease with interstitial fibrosis can be seen in many patients. If you take an X-ray, you can see bilateral lung infiltrates like miliary tuberculosis. Hilar lymphadenopathy can be there. Bronchiectasis can be there. Fibrosis can be there. Cavitation. Almost all lung findings like tuberculosis. So one of the most important differential diagnosis of tuberculosis. And patients also can have severe pleural effusion, pneumothorax. Long-standing sarcoidosis can lead to pulmonary hypertension. And there are some syndromes which are seen in sarcoidosis. Lofgren syndrome, erythema nodosum on the skin, arthritis of ankle joints, knee joints, wrist joint and elbow joint. X-ray findings of bilateral adenopathy. So, skin lesion, joint involvement, adenopathy, Lofgren syndrome. There is a genetic loci identified along with this problem, that is HLA DRB1 0301, HLA DRB1 201. These are the two genetical abnormalities associated with Lofgren syndrome. Hereford syndrome, Hereford Waldenstrom syndrome, fever, parotid enlargement, anterior uveitis, facial nerve palsy. Sarcoidosis is one of the cause for bilateral facial nerve palsy. So it's a rare cause for bilateral facial nerve palsy, but patient can present like this. Blau syndrome, triad of granulomatous lesions, recurrent uveitis, dermatitis and arthritis. So these are the syndromes, named syndromes in sarcoidosis. 30% of the patients, up to 30% of the patients can have lymphadenopathy. They also can have hepatosplenomegaly. So the whole lymphatic system will be affected here. So you can see mainly intrathoracic nodes. If you take an X-ray, many patients with sarcoidosis can have paratracheal nodes, hilar nodes. So most of the patients who have suspected sarcoidosis on examination, you can get cervical nodes. On chest X-ray, you can get bilateral hilar nodes. Ultrasound shows a lot of lymph nodes in the abdomen, intra-abdominal nodes can be there. They are adherent, firm, rubbery, non-tender and does not produce sinuses like tuberculosis. they are non-caseating lymphadenopathy. That is very, very important when we are discussing about sarcoidosis. Sarcoidosis is a non-caseating lymphadenopathy, whereas TB is a caseating lymphadenopathy which forms sinuses in the nodes. Now again, 30% of the patient can have liver involvement. Some patients can have STOT, SGPT elevation. Some patients can have enlarged liver. Splenomegaly is also common in many patients. Skin changes, around 30% patient can have skin changes. Erythema nodosum, especially on the legs. Skin plaques, maculopapular erections, subcutaneous nodules, they are called as Darrier rosy lesions. Lupus perineo. So many skin lesions also can be seen in patient who is having sarcoidosis. Whereas in tuberculosis, you can get sometimes erythema nodosum and some other clinical findings. But here there are a lot of skin lesions. You can get up to 30% of the patients. Now, eye involvement is very, very important. Anterior uveitis, posterior uveitis, keratoconjunctivitis sicca, that is a dry eye, can be seen in many patients. Nose, nasal stuffiness, some infiltration can be there. Bone, you can get bone pains, arthritis, pancytopenia because of involvement of the bone marrow. So all these things can also be there in sarcoidosis patients. Now, from emergency point of view, this is very important. Many patients who is having sarcoidosis can present with acute heart block, cardiac arrhythmias, different types of cardiac arrhythmia, because the conduction system will be involved here. That's why we get cardiac arrhythmias and heart blocks in sarcoidosis. Sudden cardiac death also explained in many patients. Again, CNS involvement can be there in many patients. One of the most important cause for bilateral facial nerve palsy is sarcoidosis. Then mononeuritis multiplex, multiple areas, single nerves are involved. Peripheral polyneuropathy also can be there. Diabetes insipidus with lot of urine output can be there in patients who is having endocrine dysfunction. Now, when we talk about sarcoidosis, you know that the patient is having lymphadenopathy, patient is having fever, all these things. The first investigation we should do in a patient who is having suspected sarcoidosis is serum calcium. Most of the patients who is having sarcoidosis can have mild elevation in the calcium, and hypercalciuria is also there. Patient can have increased urine calcium. Nephrocalcinosis, that can produce renal stones and renal failure. This is because of the calcium dysregulation is a result of increased production of 1,25 hydroxy vitamin D by macrophages. So vitamin D overproduction is the actual cause for sarcoidosis, induced hypercalcemia, and it can increase the gut absorption of calcium. So normally itself patient can have high blood calcium, but if you have doubt, we have to look for 24-hour urine calcium also. We want to know whether patient is having hypercalcemia with increased urinary calcium output. Hypercalciuria is commonly observed in hypercalcemia. Hypercalciuria is more commonly observed than hypercalcemia. That is one important finding, because hypercalcemia, if it is due to renal problem, you will not get urinary output of calcium. But here hypercalcemia is there, and patient is also losing calcium through the kidney. So sometimes you may not see the serum calcium is not elevated, but urine calcium is elevated. A moderate elevation of alkaline phosphate is also seen in patient who is having diffuse granulomatous hepatitis. So that produces obstructive type of liver disease. Alkaline phosphatase elevation is a classical finding of obstructive hepatitis. There you can get elevation of the STOT, SGPT also. One important investigation which can diagnose sarcoidosis is ACE levels. Elevated angiotensin converting enzyme in 60% of the patients with acute disease and 20% of chronic disease can be observed. Serum ACE levels has got limited diagnostic utility due to poor sensitivity, that is false negative results are common. ACE levels can also be elevated in hyperthyroidism, leprosy, cirrhosis of liver, diabetes mellitus, silicosis and lymphomas. So, ACE level alone will not tell you that patient is having sarcoidosis. Bilateral lymphadenopathy, non-caseating lymphadenopathy, then if the patient is having hypercalcemia, hypercalciuria and elevation of ACE, all together only we can make a possible diagnosis of sarcoidosis. Now, bronchoalveolar lavage can be done. It shows elevated ADA. You know that ADA elevation is a classical finding in tubercular pleural effusion. Here also elevated ADA levels are observed in patient who is having sarcoidosis. Patients with pulmonary sarcoidosis frequently have increased number of lymphocytes and high ratio of CD4 to CD8 lymphocytes in BAL. So, BAL is an important investigation in sarcoidosis. It can pick up CD4 CD8 ratio and elevated ADA levels. Now, X-ray is the most important tool to pick up possibility of sarcoidosis. Patient who is having mild fever, progressive dyspnea, all these things, when we take X-ray, it exactly resembles like tuberculosis. That is a problem in X-ray. So, stages are there. Stage 1 bilateral hilar symmetrical adenopathy, stage 2 bilateral adenopathy with parenchymal infiltrates, white shadows can be there throughout the lung fields. Reticular opacity is predominant in the upper lobe. Stage 3 parenchymal infiltrates without lymphadenopathy. Stage 4 pulmonary fibrosis, reticular opacity is volume loss, then traction bronchiectasis, calcification, cavitation, all are complications. So, multiple lung nodules also can be seen in some patients who is having sarcoidosis. Now, these are the two X-ray findings, important X-ray findings. First X-ray, you are seeing multiple bilateral non-homogeneous opacities, looks like miliary tuberculosis in X-ray. Differential diagnosis can be like viral pneumonia, ARDS, pulmonary tuberculosis, sarcoidosis, then chickenpox pneumonia, eosinophilic pneumonia. So many differential diagnoses are there. So clinical features are very, very important to make a diagnosis of sarcoidosis. And lymph node biopsy, if it is available, that is very good. And if you do a Mando test, mostly sarcoidosis will have a negative Mando test and it is positive in tuberculosis. So negativity of Mando test is very, very useful in sarcoidosis. The second X-ray shows bilateral mediastinal lymphadenopathy. But remember, when we are seeing mediastinal lymphadenopathy, most of the patients can also have cervical lymphadenopathy. We have to palpate it properly so that we will get cervical lymphadenopathy. Same patients, CT or CT chest or ultrasound abdomen may show lymphadenopathy in CT or ultrasound abdomen. There are some signs. The one is Garland Sign. Garland Sign is also known as 1-2-3 sign. It's a lymph node enlargement pattern on the chest radiograph which has been described in sarcoidosis. Right paratracheal nodes, right hilar nodes, left hilar nodes. So it's a sign. So 1-2-3 sign, it's called as Pond-Broca sign, another name for this. Lambda sign, it's seen in gallium-67 scans in the settings of thoracic sarcoidosis. Bilateral hilar and right paratracheal lymph nodes are typically involved, which can resemble Greek letter lambda. So that is lambda sign. But all these things are not required. These are explained in theoretically. But a clinical examination, good X-ray, a good pathology report will pick up sarcoidosis. Another one is Panda sign. It's sarcoidosis. Here the gallium-67 citrate scan is done. You can see appearance like a panda. So that is also can pick up parotid and lacrimal sarcoidosis. Another important investigation is HRCT or PET scan. Okay, whenever patient is having pyrexia of unknown origin, if you are not picking up the possible cause for PUO, we always depend on the PET scan. Okay, here PET scan is not that important. If you are not able to find out the lesions in a PUO only, PET scan is very, very useful. Otherwise, if the patient is having bilateral lymphadenopathy, in mediastinal lymphadenopathy, HRCT will be a better tool. So HRCT should be done if we are not able to find out any answer for his symptoms. If there is an external lymphadenopathy like cervical lymphadenopathy, simply if we take the lymph node biopsy itself, we can make a diagnosis. But HRCT will give better clue for other problems in the limb. Now, biopsy is the most important diagnostic tool in sarcoidosis because it's a lymph node involvement. Lymph nodes are involved, spleen is involved, liver is involved. So, if there is an external lymph node, we always try to take that lymph node and see whether non-caseating granuloma is present or not. If there is a mediastinal node, then we have to take a tissue biopsy. HRCT guided tissue biopsy has to be done. Wherever you take the tissue biopsy, it shows a non-caseating granuloma. So it can also be seen in granulomas are also be seen in TB, fungal infections, lymphoma, forehead body reaction, borreliosis, hypersensitivity, pneumonitis, primary biliary cirrhosis, leprosy, brucellosis, syphilis, granulomatous arthritis, lymph node draining, malignant tumors. So many conditions we can get granulomas, but non-caseating granuloma, elevated ACE levels, elevated calcium in urine, all together we can make a possible diagnosis of sarcoidosis. Now, once you make a diagnosis of sarcoidosis, you should know that we have told differential diagnosis for that is TB, lymphomas, other granulomas, fungal infection. All these conditions we have to treat the infection or inflammation with specific drugs. But here in sarcoidosis, we should understand that it is an immune dysregulation syndrome. So steroids are the mainstay treatment for sarcoidosis. Once you make a diagnosis of sarcoidosis, or if we have a differential diagnosis of sarcoidosis but everything else is ruled out, then we can try steroids. Prednisolone 1 mg per kg per day can be started initially, then slowly taper it over 6 to 12 weeks and make it alternative days. But most of the patients may require lifelong steroid therapy or alternating to steroid. There are some drugs, we'll discuss that. So steroids are mainstay treatment for sarcoidosis that has to be started immediately. As soon as we start steroids, we can see as soon as we put the patient on steroid, we can see the patient is improving his clinical features, Xray findings, pleural effusion, pericardial effusion, everything will disappear. Most of the patients improve with initial dose of steroids itself. Some doctors prefer to give pulse therapy because if there is a massive pericardial effusion, massive pleural effusion, then large dose of steroids are recommended. But routine treatment, routine patient, 1 to 2 milligram per kg body weight prednisolone is enough. Now this is a chart which tell you how to taper the steroids over the days. So initially we can start 1 to 2 milligram, then slowly taper, stop. Many patients require alternative days steroids like 5 milligram prednisolone alternate days can relieve the regression or patient can come back again with mild symptoms. So many patients may require long-term steroids. Will not be able to stop the steroid at all in many patients. But there are some alternatives like any other immune mediated disease. Instead of steroids, we can try cyclophosphamide that can be given as loading dose, and repeated pulse can be tried. And there are some other drugs that also can be tried. We'll discuss that afterwards. Lung transplantation can be tried in patients with severe pulmonary fibrosis secondary to pulmonary sarcoidosis, or if they are associated with pulmonary hypertension. Then for long-term survival, we will have to advise the patient for lung transplantation. So pulse methylprednisolone or pulse cyclophosphamide can be tried in acute condition. Otherwise, we can start 1 to 2 milligram per kg body weight prednisolone. And there are some alternatives like in rheumatology you might have learned there are a lot of drugs which can replace steroids. They don't have side effects of steroids. Like steroid has got a lot of side effects. It can produce hypertension, it can produce diabetes, it can produce osteoporosis, it can produce GI intolerance, peptic ulcers. So many abnormalities can be there in chronic steroid use. To avoid that, we can go for alternatives like methotrexate, hydroxychloroquine, azathioprine, mycophenolate mofetil, leflunomide, infliximab. All these things are alternatives. If the patient does not improve with your steroids, there also we can try these alternatives. So we have discussed one of the most important differential diagnosis for bilateral lung infiltrates, bilateral lung adenopathy, bilateral pleural effusion, and cardiac conduction disorders or complete heart blocks or acute eye involvement like uveitis. So that is sarcoidosis. The treatment is steroids. Basic investigation to be done in this type of conditions are calcium in blood, calcium in urine, ACE levels, and lymph node biopsy. Thank you.